All right, folks, we're getting close to starting here. Good afternoon. Thanks for coming to join us. If you have any technical challenges, if you can't hear me, if you can't hear Lawrence, please let us know in the Q&A section. That's also where we're going to be collecting questions for Lawrence to get to at the end of his session. We'll get started in one more minute. All right, I think we're going to go ahead and get started here. Good afternoon. Just one final reminder here. If you have any technical issues or questions for our speakers, go ahead and leave that in the Q&A section. We're going to collect all the questions until the end of the session, and then Lawrence will be working through any of those that we have that remain. So welcome to the last installment of our COVID-19 and Analytics Speaker Series. My name is Brian Kelly. I'm a graduate of VCU's Weekend Decision Analytics program focused on data science and decision analytics. I graduated in May of 2016 along with Mr. Lawrence Roakes, who's joined us today. I now live and work in Richmond, Virginia for LL Flooring, a retailer specializing in hard surface flooring. The Weekend Decision Analytics program has an active and vibrant alumni network, and I serve on the board of the alumni group. And we're excited to participate in this series of 4 talks about the coronavirus's impact to health and business. We're doing this with help from the Richmond Tidewater Chapter of INFORMS, the Institute for Operations, Research, and Management Sciences. There are some folks that I'd like to thank in particular, the Decision Analytics team at VCU and the School of Business, Brittany Graysick, Gabby Oliveira, Rachel Kaiser, Dr. Paul Brooks, and Dr. Steve Custer. They've been absolutely critical providing their assistance in this, as well as Mary Lazinski and Eric Wickham with INFORMS for their help promoting this event. Now I'd like to introduce my good friend Lawrence Roakes, the Division Director of Data Analytics for the Southwest Texas Regional Advisory Council. STRAC develops regional emergency response systems, conducts healthcare research, and coordinates healthcare policy for healthcare and public safety agencies in Southwest Texas. Lawrence leads STRAC's data analytics program and is responsible for analytics consulting, design, and implementation. He also works with database management and custom software design. He has over 30 years of experience in the fire and EMS service as an emergency responder, officer, and emergency management leader. He completed his fire service career as a captain with Hanover, Virginia, Fire-EMS, leading their information technology and data efforts. He is absolutely the guy you want to have in your corner during an emergency. He has seen it all. He holds a BA in English from the University of Virginia and is a proud member of VCU's inaugural Decision Analytics class, and once held, I don't know if this is still the record, but once held the longest commute record for the Decision Analytics program, completing his final year while living in San Antonio, Texas. So with that, I'll turn it over to Lawrence. Thank you so much for being with us today.
Thanks, Brian. I really appreciate that. I really enjoyed my time in the Decisions Analytics program. It was and continues to be instrumental in my career. Moved me halfway across the country to Texas, which was a great opportunity, largely because of that program. And Dr. Custer, Dr. Brooks, all the folks at VCU, I appreciate the effort they put in the program, the opportunities that they present. And I think the speaker series is a great way to kind of share our experiences. Data and analytics has such a wide variety of work and work experience and things that you can do. It never ceases to amaze me, the paths that we all go down. So good to see you all again, and we'll get started with our topic for today. We're going to talk, as this series is about COVID, we're going to discuss how my organization, the Southwest Texas Regional Advisory Council, participated in, helped lead, and experienced the COVID pandemic crisis for the last 7 or 8 months now, really starting in early February for us. So we're going to talk about how we triage the situation, how it first presented to us, how we tried to wrap our arms around it, and then how we progressed through sort of a treatment phase, what we applied to it, and hopefully we've gotten to a stabilized business model to help maintain the ongoing response to this COVID crisis. So we're going to talk a little bit about what STRAC is. We're a little bit different than some organizations you may have been exposed to. We're going to talk about the process that we developed and continue to maintain, manage, and develop to this day. And then in the end, we'll talk about a couple lessons learned that directly apply to our organization, but I think also can be helpful to anyone that's faced with whether it's a actual emergency crisis or even just a work process in your regular work or fast moving challenges. I wanted to post my commute mileage, 1,519. It's one of the few records that I believe I still hold, although that's not true. You know, no matter how small your achievements are, promote them. So that's about how far it is. I'm always a Virginian at heart, probably end up there someday, but Texas is a nice place to come to if you get a chance. So STRAC, let me give you a little introduction so you can kind of have a little bit of a background as to where we sit in the emergency services environment in Texas so you can have some context. We're a nonprofit. We're quasi-governmental. We're designated by the State Department of Health Services, and our charge from them legislatively is to help develop regional trauma and emergency healthcare systems. We're not a direct responder. We're not directly responsible. We don't have hospitals and ambulances working directly for us. We help coordinate those activities between the various entities that directly provide them to give some structure and some efficiency to the system. We cover an area of about 26,000 square miles, which is that gold area in Texas. There are actually 22 of our regional advisory councils that we have. Just to give you some scale, that little area is bigger than West Virginia. It's about 60% the size of Virginia. So we're sort of a state, you know, everybody from Texas, we're bigger and badder than everybody else, but it's a big place. So we're basically the size of not the size, but the function of a state agency, including San Antonio, the 7th largest city in the US. And we have a real wide variety of urban, suburban, rural, and what we call frontier areas. So we have a wide customer mix of both population and agency size to deal with, from very large, sophisticated hospital systems in and around San Antonio to much smaller, local, privately owned facilities out in the rural and frontier areas. So it's an exciting place to be, to see a lot of big city issues as well as very rural, smaller scale type issues. We serve about 2.8 million people across 22 counties, and we interface and work with 74 general and specialty hospitals, several level 1 trauma centers, PCI and stroke centers, plus another 70 or more Fire-EMS agencies and air medical providers, helicopter companies that transport medical patients. And we're fortunate that in San Antonio, we have the military's largest and only teaching hospital. Every branch of the military comes through San Antonio. It's a very large trauma care center for us. So we have available to us a lot of research and resource opportunities with the Army, particularly, and the Air Force. Our mission statement is to reduce death and disability. We work with traumas, disasters, acute illnesses. We are a planning and coordination unit. We help develop regional emergency response systems. So how do we do that? We're sort of Switzerland. We sit in the middle and provide a place for people to get together, to meet, to discuss ideas, to decide things, and then put a system in place across our 22 counties that's good for the patient. So we work a lot with collaboration, consensus, and cooperation. We call it coopetition. Hospitals, by their very nature, are designed to help people, but they're also business entities that compete with each other. So we hope to get them in a neutral spot where we can develop things like a stroke treatment regime for ambulance companies that all the hospitals agree is the best way to treat stroke patients, for example, across the region, so that we're standardized, everyone receives the same level of care no matter where they are, no matter what their resources are, and that everybody's on board with those things. Even though we're quasi-government, we are a very entrepreneur-driven organization. We're very kind of lean, fast-moving, quick to respond, quick to adopt new ideas and new technologies. We truly believe in servant leadership, and ultimately we do what's right for the patient no matter what those decisions are. Now we do that through a lot of different committees and programs, some of which are on the right side of the screen. Acute care in the case of cardiac or stroke events, trauma events, emergency department operations, injury prevention, hospital preparedness for disasters. What will a hospital do if they lose power, if they lose water? How do they evacuate? How do we support those with maybe generators? We do a lot of research in conjunction with our hospital partners and our military because we have access to a lot of data sources, a lot of education efforts. We run the South Texas Crisis Collaborative. Mental health is a big issue right now across the country. So we do things like route folks, especially our homeless population, to mental health crisis centers instead of hospitals, since they're better treated to treat those things. We run the Regional Medical Operations Center that's now been up for its longest deployment ever from February 1st until today, where command and control is run out of. We have a region-wide dispatch center called MedCom. We run the state's Emergency Medical Task Force, which is a collection of ambulance responders across the state that became called out in a disaster. We were the first big city in the country to deploy whole blood in an emergent atmosphere, and we do a lot of Fire-EMS agency data. So basically, how do we do that? The top picture is what we do. We meet a lot. We have a lot of meetings. We have lots of people in our building every day. We have a big conference center. We kind of pride ourselves. We never take a vote, that we try to work to consensus. In that room, you'll see hospital CEOs, you'll see military leaders, you'll see fire chiefs, you'll see EMS chiefs, you'll see all sorts of people addressing problems every day. And the result of that work are some of the deployable assets below that we run. A mobile medical unit that's a tractor trailer truck with a bunch of tents that's basically an emergency room on wheels that we can take anywhere in the state. Then at the very bottom are ambulance buses that can transport 20 folks at a time instead of one ambulance in a disaster situation. We run infectious disease response units with the medics there dressed up in the gear. And we do a lot of that in kind of my area of work, which is the data and analytics area. We develop our own software. We use COTS, Therefore, commercially available software, and we implement that against policy, procedures, and administration to help make things better in the region. So that's a little bit of a background about what we do and how we interface. How did we come to be a part of this COVID response, since we're not a hospital and we're not an ambulance and we're not the State Department of Health Services and we're not the public health. We're kind of the coordination center. So some of the roles that we're charged to working with in any emergency, but certainly in COVID-19, are many of these functions that we either help administer, physically run, or contribute to. Testing of actual public and healthcare workers for the COVID-19 virus. We were a regional distribution center for personal protective equipment. There still is a little bit, but early on there was a huge shortage of medical gloves, masks, gowns, just basic infection control equipment that can protect healthcare workers and the public from spread of the virus. We have a warehouse that we would run that out of and distribute to hospitals, doctors' offices, EMS agencies. We're large in command and control. Our team is part of the unified command system for the region, so that they are the decision makers on how the region will perform. Obviously, we run data analytics to help support all these functions. We help staffing coordination, bringing in supplemental doctors, supplemental nurses to build out the hospital system when it's stressed. We distribute, purchase IT hardware to set up testing systems. We directly support hospitals with either staffing, data, PPE, whatever they need, and we coordinate with state and federal partners to kind of get all this done. So we have a very wide-ranging reach into the emergent role in Southwest Texas. So let's talk a little bit about what happened to us in COVID. And our role in COVID, as you can see so far, is very operational. We're in the street, we're in the hospitals, we're in the EMS agencies, we're running testing centers. It's very hands-on, it's very operational. It is not high-level predictive models of where this virus may spread and how fast. We're the folks that kind of take those types of predictions and then put them into actual action to make things happen, to help respond to the event. So this started for us in early to mid-February. We were one of the first places in the country to get evacuees, American citizens, directly from China, primarily Department of Defense folks that were coming in from China. We have Lackland Air Force Base literally behind my office, and that's where they disembarked at. So before a lot of people in the country had really gotten involved in any real COVID responses, we were getting the first evacuees in San Antonio. When the evacuees come in, we contain them, but if they need to go to a public hospital, we come in and help with the transport, the infection control measures, and those types of procedures. Just as they were arriving in early March, the cruise ships started getting evacuated, and they also came to San Antonio. There were a few other places around the country, but a lot of those folks came to San Antonio as well. So by early March, we were in full-blown command and control mode, and by mid-March, we had community spread. So in the space of about 3 weeks, 4 weeks, we went from a few evacuees from China that we thought maybe this won't be so bad in the US, it's not going to be terrible, we'll just be able to contain it, to all of a sudden we get hundreds more cruise ship evacuees, to a couple weeks later, we're seeing our first community spread cases pop up, which pointed us to where we were probably going to head on an accelerated pace. Our first response was we set up our medical operations center for our STRAC region to get ahead of it a little bit, tried to contain the evacuees at the local Air Force Base, as well as a state infectious disease center that happens to be in our city. And we started the initial spin up of local plans, logistics, and systems. Those things take a little time to get spun up and to get set up. So in those first few weeks, that's what we were doing. And then specifically, when it came to my group, as those plans were being made, the demands for our data came in. And this is where we'll get more specific about how the data came in. So initially our charge was, how can we measure healthcare system impact, if there is going to be one? How can we develop tools for decision makers? And ultimately, how can we develop a testing plan for first responders and healthcare workers? So this early first response was, we're not quite sure how bad this is going to get, but if it does get bad, how can we judge the impact on our system to know when the system is in trouble before it gets there, or how much of a reaction force we need to apply in order to keep it out of trouble. Those decision makers, what can we develop for them that is a simple, easy to understand set of tools where they can look at all the data that's coming in, balance with the things that they're getting from federal and state partners, things they're getting from CNN and Fox News, and see what's really happening in San Antonio. As we've seen, the virus had a very disparate impact across the country. New York City's experience is different than San Antonio, is different than Boise, Idaho. So there are some similarities, but the reaction and the level of severity were greatly different. And we knew initially one of our charges is take care of first responders and healthcare workers. If we lose that group of people to the virus, we have no backup. We have no one to treat and solve the problem. So if we can get an aggressive testing plan for those folks, then we can try to protect our safety system, which will ultimately help the community and help our spread. So that's where we started in the very beginning. That was the first few weeks of That's the plan, and how do we spin up? So what did we put in place? As we move from that kind of triage, our initial marching orders, if you will, into the treatment where we actually started deploying data tools, we developed a plan where first off, we needed regular situation reports, both for unified commanders, political leaders, and healthcare leaders. So my group needed to develop tools that the mayor of San Antonio, the judge who runs the county, the CEOs of major healthcare systems, the general in charge of the local Army Trauma Center, those types of very, very high level decision makers can quickly ingest a lot of information. As you can imagine, every day they have a lot of information coming in just normally. And now COVID on top of this was not the time for big, detailed, long papers. The time for that came and will come, but we needed quick things where they could spend a few minutes and make some general course headings and place action plans in place. So we needed big picture, we needed distilled information, and we needed talking points. Oftentimes these tools were literally talking points for mayors' press conferences and things like that. So part of our limitation was our main tool is Tableau that we've used for years here to distribute information. And that's a great tool, has a lot of capabilities, has a lot of neat interactive things that you can do. But for this targeted group, we really needed to limit that. These people are going to look at email, they're going to look at their phone, they're going to look at emergency operations center, large display boards on 86-inch TVs. And often, a lot of times, they look at print. They are not able to take the time to go out and play with dozens of filters and dozens of what if scenarios. They may have some folks that do that for them, but they need the down and dirty kind of answers. So we tried to design things for them that were simple, straightforward, and pointed them in the right direction. Also knowing that much of this would end up in news outlets, social media, and on official websites, both of government agencies, our website, as well as individual hospital websites. So there's concerns over things like HIPAA, data rights. Whose data is this? Who owns it? What agency agreements are in place? Is it legal? What's the perception of what you publish? What are the public positions of our especially political leaders? And what's the distribution? So the idea was to get the right data out to the right people at the right time without infringing on individual patient rights, without violating any agreements where, for example, we host a lot of data collection systems for a lot of the agencies in our region. And a lot of that data is governed by use agreements where each agency obviously has access to their data, but we cannot share one agency's data with another agency's data, even though it's the same software platform, unless they explicitly agree. Well, now we're in a situation where day to day, there's no real reason for them to explicitly agree to share data operationally, but now we need to because we need a much bigger picture. So some of those things had to be worked through, and they were worked through quickly and well, but they had to be worked through before we could just say, well, we've got all the data, it's all right here, we could just mash it up. Well, sure, that's sort of the easy part. The hard part is getting everybody to agree that that's a good thing and what level that agreement is. As it turned out, some of the sources, some of the things that we use were everything from typical SQL databases, ArcGIS, Excel, down to SurveyMonkey data for ad hoc. Today we need to collect information that's probably very, very short lasting, and you can have a great idea to show it out on SurveyMonkey and dump it down as a CSV, to JSON feeds, to WebEOC is a virtual emergency operations center software that runs many of our operations when we get into this mode, from hospitals and EMS agencies and public health agencies and our own databases. So a lot of the challenge was to mash all of that up into one cohesive picture that comes from multiple sources on different platforms, so that we do what's in the graphic here. The sources, the presentations, the measures deliver a clear and consistent message, regardless of their source and regardless of their platform. So one of the things we developed pretty quickly, and it's something that we did not have in place before, but I think is going to continue, is especially the political leaders, but also the hospital leaders, we needed a fairly quick way to judge how much resources were left in our healthcare system and how quickly they were being used or were they being used, and what are the measures that we can use to do that. So we collected data. We've always collected these data points kind of separately in different systems, but we convened several of the hospital CEOs. We convened several of their doctor staff that were interested and were data type doctors, and came up with a fairly straightforward weighted stress score where the hospitals report things like how many staff are sicked out, how many available beds are there, how many patients can you take, how many ventilators are available since this is a respiratory emergency, what's the status of your intensive care unit, is it stressed, is it not stressed, what's the status of your emergency department. And we agreed on the measure value ranges, and then we agreed on their contributing weights, and we came up with an overall system stress score. Now, this was designed to be an emergency manager's high-level look at, are we good or bad? If we're bad, I take more aggressive action. If we're okay, I don't need to take as aggressive action. It's not meant to be, nor was it used as a way to administer hospitals. Are they doing well? Are they not doing well? It's much, much too high level for that. It ended up that this was kind of gravitated to, and since there was agreement among the hospitals, and this became a community measure across our whole region, and actually became part of the mayor's press conference each night on where we were on this scale. Was it getting better or was it getting worse? Honestly, when we first did it, we were kind of like, what can we do pretty quickly to give us a thumbnail sketch? And as we went along, we fine-tuned and got better. And now it's developed into, I think we're going to have a research committee convene after COVID and see how we can look at more, a little better research, a little deeper look into how we can make this a little more granular, a little more finite. But it's an example in a true emergency situation as emergency responders that most of us from STRAC came by as we need a quick answer to an immediate problem. And even if we refine as we go, it gives us some information to judge how well we're doing at a high level. Same thing, but these are individual hospitals, so you can see how the hospitals compare against each other. Red is stressed and bad, and green is not so stressed and not so bad, so that we could dive down and see where the specific challenges happen to be. These are some examples of things that we publish daily. They are straightforward counts and trends and percent increase or decrease day to day and week to week. Again, to give those high level folks a view on a daily basis of where are we, where are our trouble points, which systems are stressed with patients, are we declining, are we getting better, are actions happening, are they not happening? You can see the curves to the right there. For the first 4 months, we were pretty flat around 100 patients. Then we got into late June and July, we had our big peak, and now it's slowly declining and slowly dissipating as the patients or the peak has passed. There's a lot of conversation about why we had the peak and why it stopped. Depending on who you are, you have your own opinion on that. It's interesting, we've had several universities in the area do some studies where they were predicting curves all along this from day one, from February. They're predicting this is where we're going to go and this is where we're going to be and this is when it happens, and then using our data to prove were they right, what was really happening with inpatients. And we're looking here at just hospital inpatients. It has nothing to do with public spread. It's just people that made it to the hospital for the infection. So that's we felt we had a control population, right? Because we can get to the hospitals and go, how many are sick? Compared to the general public, that's a really, really hard number to get with reality if you have to call everybody in San Antonio and go, hey, do you feel bad? So this was a definitive case of how we did this. And actually a couple of the models sort of use these to extrapolate backwards into population and determine how far down that herd immunity curve we happen to be. A few more operational things, bed statuses and contribution of hospitals to bed statuses with percentage of empty beds compared to how many beds that they had available. And then some age studies on were there particular age groups that were increasing or decreasing. Can we send those age groups based on, are they pediatric, are they elderly? Can we send them to care systems that aren't hospitals, maybe improve the care in a nursing home, for example, to try to get some bed space in hospitals. So testing came up. We started testing in San Antonio, just first responders and healthcare workers, and we developed a software system to do that on the fly because there wasn't such a thing. It went well, so we expanded it to our region, testing nurses and first healthcare responders. And then as the crisis expanded in Texas, the state picked up our system to do testing for the whole state. So we became responsible for the data, the software, and the system for public walk-up testing, nursing homes, correctional facilities, and targeted outbreak facilities like meat packing plants. So in the middle of our local efforts, we were also running a state effort where we developed a call center where you could call in and schedule your test. We'd schedule mobile teams to go out and administer these test sites. We'd then ship the tests off to labs overnight, get the results back in, and then notify the people of their test results electronically, phone calls, and through a website. The screenshots, a picture of the little software system that we developed to run that. Because of the state input and the size, we spun up a second Tableau server. We went from our public health region to all 8 public health regions in the state. And that caused a lot of work with reporting segregation and aggregation because we have HIPAA data so that the public health regions can see their patients, but not the other public health region patients, so that we maintain the legality of the HIPAA process. So this process was running parallel with our local one. This had some bigger state views. These were views that went across the state and up to the governor's office. How many tests, which counties have had tests, what their volume was, percent negative, how long till test results come back, are the labs being effective, do we need to change labs, down to regional levels of their test volumes, their positive test percents, their testing. And then there were a lot of other things going on as well, where public health regions could look up specific patients, they could download specific patient sheets. We were doing a lot of downloads to state, uploads to state systems, downloads from labs, direct personal contacts, and then a lot of ad hoc reports from the governor's office. So that's what we did. That's what we're still maintaining. That's what we're still running. The pace has slowed down quite a bit as the COVID crisis has waned a little bit and has gone into a more less frantic mode, and how we used some of our data tools to at least help inform folks up and down the chain. So now we're looking at where do we go next? And we're right in the middle of where do we go next, and we got a curveball. Right in the middle of meeting for where do we go next and how does the next year look for COVID, because we think we're going to be in that business for the next year. A small thing called Hurricane Laura hit. So we switched gears for a 2-week deployment, opened a second command center. We had to move some patients around out of hospitals. We evacuated the eastern quarter of Texas, everything east of Houston, deployed 150 ambulances, 10 ambulance buses, and some paratransit vans in order to evacuate nursing homes and hospitals. So then our data system started looking at resource allocations, mission priorities. How do we translate those while we're running the COVID? So we start to do things like dashboards to track resources in a particular sector of operations, so that different sectors, this is just one of our sectors, where they can see the resources they have available, how many missions can they take on, what type of vehicles. The map in the lower bottom shows deployed vehicles that are evacuating residents east of Houston. San Antonio's kind of in the lower left. So you can see the little caravan of trucks running back and forth from east of Houston back to San Antonio, so that we have real-time visibility on those. And we can run analytics across their trips and whether they're closer to something than somebody else. So we kind of switched gears and did about 2 weeks of hurricane, and now that's over. So now we're back to COVID. a couple lessons we learned from our process, especially since we're very, very operational in this mode and not really research-based, but we're real-time operation is, and I really believe this, the DAP program really gears you up to do this type of work. And a lot of it is the exposure to so many different types of systems and so many different types of programs and different types of people and different types of experiences. I remember when Steve was first talking to me about it, that it's maybe more of an MBA, the way I looked at it, an MBA data degree and not a data scientist degree. And that's the fun part where it's nice. That's really a lot of what I do is how can we put the resources together? How can we turn out a product that will meet the operational needs of these systems, whether it's at whatever level of analysis, and how do you think on your feet? And how do you get that done? Even if you're not the expert, who do you pull in? How do you get it done? A big one is erase doubt when challenged. When we were told we were going to be running a testing system for the whole state, several of us in our IT group were like, yeah, how? Oh, and by the way, you've got 3 days for the first deployment, and we need to get that software spun up. Well, there's nowhere else to look, like you just do it. So if you like challenges, that's fun. That's interesting, but erase the doubt and go for the challenge. Especially when we're dealing with a wider public audience than some of our normal analytics, it's really important to nail down the deliverable. Who's going to be using it? What's their use? And what are the landmines? Especially true if you deal with industry leaders or political leaders. Is critical to know that, so that your analytics are in line with what they think they need to know, and not what you think you need to give them, but what are they really looking at? What are their other things that are pressing on them that you can help answer? There's never any substitute for quality and consistency. Those things pay off over the long run. We found out that direct, clear, and simple and fast pay off in a crisis. And I don't mean to ignore and be wrong and have wrong numbers, but mean, median, and quantity explain a whole lot in this world. And those often are the measures that are enough to get you started and to get major decisions made, especially when the clock's always running and there's not the time in the beginning, at least, and even throughout some of the later stages, to rely on the next one, which is sophisticated models are really, really important. The COVID prediction models were critical to how we went. However, they can be messy. They take a little while to develop. They require folks to know the context, and they change, which is a good thing. It's good that there are competing models and competing ideas and different inputs. But the simple averages and quantities kind of give it a base to either confirm or not confirm what the models have put forward as where you think you might be able to go, and be ready to educate other users if they become, especially if they become frustrated that yesterday it said this was going to happen. That same model today said it's going to be a little different. That's normal. That's a good thing. But when decision makers are trying to make decisions, that can be a little frustrating. Plan like everything you do is going to end up in the newspaper, because it probably will. And double check, because if you double check, they won't. If you don't double check, they will. Small movements in numbers get noticed, and they can have important impacts, and sometimes it's just a credibility thing. That's been a pretty down and dirty overview of some of the things that we've done and some of the things that we've been concerned with. I'll close with that. I'm ready for some questions. If you notice in the bottom, we're hiring. We need more analysts. Go to indeed.com, and I appreciate your time. I appreciate the opportunity to speak with you today and talk with some old friends, and I'll leave you for questions.
Thank you, Lawrence. Thank you so much for doing this today and your fascinating presentation. I really enjoyed it. Before we get to those questions, I just want to take a minute to remind our visitors that Lawrence is our final speaker of 4 on our COVID-19 Impact on Health and Business series. we have three previous speakers: Greg Bucko of Marriott Hotels, Dr. Pritam Ghosh from VCU, and Dr. Fern Halper at TWI. Thank you so much to all four of them. To Lawrence, thank you so much again. These talks were organized by VCU's Decision Analytics Alumni Group and the INFORMS Richmond Tidewater Chapter, with the crucial assistance from the School of Business's Dr. Steve Custard, Dr. Paul Brooks, Rachel Kaiser, Gabby Oliveira, Brittany Graysick, along with Mary Lazinski and Eric Wickham from INFORMS. So thank you so much to everyone who's been working so hard to put this together, along with my Decision Analytics alumni colleagues. So let's take a look at some questions that we have for Lawrence. If there's any others that we want to get out there, please put them in the Q&A box down below. So what is life like for someone in quarantine on an Air Force base?
If you can probably think about your first year dorm in college, take away the roommate, take away the ability to leave, and take away your choice of food at the cafeteria, you'll be fed, you'll be cared for. Oh, and there'll be daily wellness checks. Initially, for the first few weeks, there was no internet and no TV. So they were literally in a room by themselves. That was addressed pretty quickly because I think you go a special type of crazy locked in a dorm room with no entertainment. So we provided TV and internet. The whole concept initially was, if we can contain, let's get our folks back home. China and cruise ships aren't the place for them. Let's get our folks back home and maybe we can contain it. It was a great effort, but it wasn't possible. So it wasn't fun. And there were some folks that weren't happy with being there, especially after they're well and they didn't catch it. But they were kept there for at least a 14-day quarantine. Initially, they were kept for a couple of weeks until we realized, well, maybe 14 days is fine. Understand too that a lot of this is happening fast, right? Like right now, we know so much more about COVID. We know so much more about how hard it is to get or how easy. In February, it was the end of the world. We thought in San Antonio, we'd have tens of thousands of infections in the hospital. And thank goodness that didn't turn out. So it's kind of like being in a dorm room with none of the good parts. But it got better and we slowly released them as we could check them out. And we were fortunate we had a place to do that. We were one of the few places in the country that had spare rooms to do that, and we could contain it. I wouldn't advise it if you can help it. I wouldn't do it if you can help it.
Not a good vacation.
No, not a good vacation. Well, especially, it's one thing if you're a DOD employee, okay, fine, kind of part of it, but you just came off a cruise ship, right? And now we're going to put you here. Yeah, not fun.
So your comment on DOD is a good segue to this next question. Hello, sir. I'm an Army officer who was involved in the COVID pandemic in Italy when it started in March and April, and was heavily involved in the emergency operations side of the house as a company commander. I'm wondering if there have been any specific tools that you and your team may have implemented for the military to be able to utilize in future tracking and spread predictions. If not, could you speak a little more on some of your interactions with military leaders specifically at your STRAC meetings?
Yeah. So a couple of things. I'll tackle the second one first. We are really, really fortunate to have Burke Army Medical Center in our city. Those folks are awesome. They do, like I said, all training for everything from medics to doctors and nurses for all branches of the military. They have one of the best burn centers in the world, one of the best trauma centers in the world right here in San Antonio. And they treat patients from our city. If you're a trauma patient, you can go there direct, which is a great benefit. We typically have 1 to 6 of their fellows, doctors working in our office doing research all the time. It's a great relationship because they can use us as a testing ground, if you will, for some of their programs, and we can use them for the same thing. It's a great relationship. Awesome, awesome people. I think some of the things that we learned that we scaled up maybe to the state level, I think can translate to the military environment. Our biggest benefit was we could get data from the hospitals. So in the military setting, if you can get it maybe from your field care centers, or if you can get it from your deployed medical resources, I think that's helpful. We did not do any prediction spread models. We were plenty taxed with just doing operational type things. I could put you in touch with some stuff that did some of those spread models, but honestly, they're everywhere, right? CNN and Fox and everywhere else, but I can put you in touch with some of those people direct. I think a integrated system on a platform, I'll give you an example. We use Tableau because honestly, we can distribute it across our region quicker than anything else. We can attach to more things. It gives us a lot of flexibility, a whole lot of flexibility. So taking a platform like that and then plugging in all these other sources and all these other analytical methods, and whether it's coming straight out of a database or whether it's coming out of an R routine, that was our biggest challenge, is how can we scale up and get the data out to everybody that needs it quickly. So it may be an offline, maybe we need to chat. My information's on there, so or we can get it from Dr. Custer or Brian, but I'm happy to talk.
Great, thanks, Lawrence. So the next couple questions we got, I would say all fall under the umbrella of your roles and responsibilities within the organization specifically, whether you're managing or developing these dashboards, and then the IT resources and analytic resources. How big were your teams? And how long would you say it took to develop this project?
So in the nonprofit world, generally you're very lean and mean. And we depend largely on grant funding. There are some state revenue streams, a few federal revenue streams, but those streams are fairly variable. We're a pretty big organization. We have about 75 employees total. Our IT group was really doing this, was really me and a half a person. So yes, management, yes, high level deployment, but you know, a division director at STRAC means you get your hands dirty a lot. It's not a boss only thing, no matter what department you're in. Because again, we're the folks that kind of bring the folks together to have the ideas. And sometimes we do the physical work, but a lot of times we are setting the table for folks outside our organization to do their own work, if you will, right? Now, in this case, we took a lead role. So the simple answer is you work a lot of hours. When you're on deployment, which is where we are now, in that footing, you work a lot of hours because you do what you have to do to meet the mission needs. The nice part is at a place like STRAC, if you can find it and if you like it, is you can make your own decisions without a whole lot of overhead. You're responsible for those. You have to defend them. You have to be somewhat right. But you can enact things quickly, and we can move fast because we don't have a lot of procedures and levels to jump through, right? There's just kind of one. There's the boss and me. So if we decide it's okay, we do it. Now, having said that, you're managing and producing at the same time. So a lot of what you saw, we STRAC decided to do it, but I did it with some help from some other folks where they have time. We've got a couple coders on site doing database and application. It's a very, you'd almost have to come down here to see it. It's a very strange organization. We do a lot with a little, and it's kind of a special type of person to get into this in a way, because you want to have, you have to want to live in that type of world, where you're doing one thing for this half hour and the next hour you're doing something else and you're jumping around to follow the needs of where they are. Now, the last 8 months have been very, very, I've been here 5 years. It's never been like this. We've never had a deployment last 7 months. We do hurricanes, 2-3 weeks, tops, maybe a week. And you can do anything for 2 weeks, right? That's not hard to do 16-hour days for 2 weeks. I'm not trying to scare you off. That's just deployment. This is a weird deployment because it's long-term, and that was a new experience for us, which is another reason that we're hiring more analysts, because we realized that, you know, day to day we're fine, but we can't handle this level for this long. That's a pretty rambling, not a great answer, but we are unstructured, maybe. Always doing ad hoc teams, always doing right people, right time, regardless of role. It is not a structured corporate environment, which is exciting. If you can live like that, it's exciting. You get a lot done. You get to take some chances.
Definitely my experience in the field as well, where it's, you got to have that hacker mentality to just dive in and start working.
Yeah,
So,
there's no playbook. And I love my time at VCU. Coming from my background, it was incredibly enlightening. I really thought day one, this was going to be very scientific and very structured. And there are rules and there's maths and there's all those good things. But I think it does a great job to teach you how to learn, to teach you how to, I remember sitting through Dr. Brooks's class thinking that was some of the coolest stuff I'd ever seen. And I understood about 20% of it, right? But if I wanted to, the resources were there to go deeper. But I need to know, that's a great tool. I can get somebody to do that understands it and can do it, right? I don't have, and I've got things I can do that somebody else can't do. So if you can take those and not try, a lot of people, me included, I need to understand and know how to do this myself. Well, you can't know everything and you can't do everything. You can't be an expert at everything. So be willing to be part of a team and give those things up. We have a guy, we had just hired a guy. We teach classes of various types to EMTs and nurses and things. We hired a guy to run that program and run our conference each year. We have a big conference with about 700 people we bring in. He had just been here like 2 months. He got put on my data team. He's an instructor for, like, he knows what a spreadsheet is. We taught him how to do stuff. Hey, can you collect this data, keep this spreadsheet clean, and input this data? It's down and dirty, but that's the way we're going to do it. And you might have to call around the hospitals and get them to tell you the numbers off the phone, but can you run this? Yes. Boom. He is now a data cleaner. Done. Right? And that's what you got to be able to do.
Great. Thank you, Lawrence. We have a question from, I believe, one of our old classmates. Eric Thompson is reaching out.
Yep.
If you go back to the start of the crisis, response in STRAC, and take one lesson learned, if you could distill this whole experience down to one lesson, what would it be?
That's a tough one. Probably, it's easy in hindsight. The biggest lesson, and I keep relearning it, but I never do it, is to slow down. In a pace like ours, there's the drive to give an instant answer and produce it and do it quick, and that's important. But that also leads to some misadventures. Take a breath, slow down, step back if you can, and take the time to really understand what's going on. While understand there's 6 people screaming, I need to know, I need to know, I need to know. But sometimes you follow those rabbit holes and you're counterproductive. So in a way, it's slow down, because even producing simple little bar charts of how many people in the hospitals, it's always harder than it looks, right? Like there's always weird data, and tomorrow the numbers are crazy looking. Like it's simple when the mayor pulls it up and it's like, hey, that's cool, that's awesome. But it takes more time than the sponsors think usually. So that slow down and take your time, I think, would pay off, because we don't have wasted effort.
That's a good segue into another one of our questions. How do you validate data like this, where it's unstructured? Probably, you mentioned you're calling around to different hospitals. Is there a way to do this?
Yes. So part of it is delegation, right? First off, especially if you're a small shop, you can't do it all yourself. So you have trusted people. We have some really good administrative staff. Part of it is ongoing education. So some of those folks that we pressed into roles were literally, so the hospitals all have these very sophisticated, awesome patient management systems that have every data point in the world you'd ever want for a patient. They're not going to give you direct access to that. pulling that directly from them would be the way. That's not going to happen. That is, highly proprietary information. It's competitive information. So all we can ask for is, can you give us these specific structured questions that we'll give you? They're not going to let us scrape data from them. So how do you do that? Well, we ended up, honestly, having them fill out a spreadsheet every morning. So checking that's having somebody you can depend on to literally go, wait a minute, yesterday you had 100 patients. Today, how do you have 10,000? Oh, 2 zeros. Now, did they type it? Did we type it? I don't know. But check and double check. And we actually had a committee. So we took myself, a couple other folks, and a couple folks that in our organization don't ever deal with data, and said, hey, before we send these things out every morning, because we're kind of, that ad hoc, run the filters, play with it any time of day, didn't come into play with these high level executives. Reports went out at 9 a.m., 11 a.m., 1 p.m. It was a very traditional, old school kind of way to report. We had them check it. We had these people that didn't know kind of what they're looking at, check it. Did it make sense? Did it pass the eye test with you? Because sometimes you can get too deep in your own work, right? You don't see it. You're like, oh, geez, I know it's right because I did it. It's got to be right. So that worked for us. And we formally did, look, before you sign off, reply back to me on my Slack channel that you saw it and it's good, or it doesn't go out. So we put some of those things in place. It's hard and it doesn't stop. I wish I had the secret answer, but pay attention, be careful. That's your double check, check it. Even the simple ones are the ones that kill you, because everybody can figure out the simple one. Oh, you're 20 off today. Oh, it must be wrong, right? On a scale of 5,000, it's off 20. Okay, you're right. And they're right. But I don't have the secret. I wish I did. I did find, though, I was skeptical. I found that people that aren't typically analytical people, if they're dedicated to their job and they care, they can be incredibly helpful with that fresh look of, that just doesn't look right. I might not even know why. That's really helpful.
So I think we're going to leave time for one more question, and I'm going to be greedy and make it my own question. You mentioned earlier that you support folks that are urban, suburban, and also frontier communities. How does the threat of COVID differ or not differ between those three groups? Is it more? What are the challenges between the three, or are there pretty much the same similarities across all three?
The disease, and I believe probably the rate of spread is pretty similar. The problem is when you get to the rural and the frontier. In San Antonio, we have tens of thousands of hospital beds. We have awesome, great big hospitals. They're huge. We never ran out of space. They were challenged. But now we go to Eagle Pass, that's on the border with Mexico. They have a hospital that has 40 rooms. It doesn't take long to get overwhelmed. And that's their problem, is they run out of space. They run out of nurses. They run out of doctors. They are in a much deeper crisis quicker than we ever will be. Even though we have more people, we have more, the resources so at least so far I've outpaced it. So the challenge there is, and they're remote, and it's hard to get people there, and it's hard, you can't just build a hospital. What do? You do things like tents. You do mobile tents. You do, we hired a caterer with a canteen because their hospital kitchen couldn't keep up, and put it in their parking lot. It's those little things that we help with. Even in the city of San Antonio, we had hundreds of federal funded nurses and doctors in place to help supplement the hospitals. We sent hundreds into the rural and frontier hospital, Navy teams, Army teams, private contractors, because not only are they stressed out, guess what? That poor nurse that's used to taking care of 5 people in a ward in a day, now she's got 8. And that doesn't sound like much, but you just, added 50% to her workload. She's less efficient. Some of them get sick. If you want to expand beds, many hospitals have spare beds. They're not excess capacity. They're either in rotation, they're being cleaned, they're being remodeled, they're being switched to this type of ward. They need people. You need more nurses and doctors. You can turn a cafeteria into a hospital ward, but you need doctors and nurses. So the challenge with them is getting them they're just not deep because they're small. They do an incredible job, but they have no depth because they're small. They're used to that pace. And now, if I add 50% load to a major hospital in San Antonio, it hurts them, but they have resources. They're good to go. I do that. The volume's not as much down there, and they are really, really, really hurt. So that became almost a bigger crisis as it did in the city. The city was in some ways a lot easier. It's just with size, you get a lot of advantages, and when you're small, you just don't, and there's not much bench.
Well, thank you very much, Lawrence. Thank you for the time today, and thank you to everyone else who attended and participated. Thanks for the great questions and answers. I think that's going to conclude it for now. This has been recorded and will be made available to folks later. If you have any other questions, please reach out to Brittany or Dr. Custer or Lawrence if you have his contact information as well. So thank you so much to everyone for participating. We're going to cut it off now.